All right, let's dive into one of the most intense situations in all of medicine, the first 48 hours after a major vascular operation. We're going to pull back the curtain on this incredibly critical window, a time when a patient's life is literally on the line, long after the surgery itself is finished. You know, it's so easy to think that once the surgeon says we're done, the danger is over. But for the most fragile patients, that couldn't be further from the truth. The surgery? That's just hurdle number one. The real marathon, the true test of survival, begins right now. So, straight from the operating room, these patients are wheeled into the intensive care unit, the ICU. And let's be clear, this is way more than just a recovery room. Think of it as a high-tech command center designed specifically to manage the absolute physiological storm that's raging inside a patient's body after this kind of procedure. So, who ends up here? Well, there are some key things that tell the team a patient is going to need this level of care. We're talking about older patients, folks with existing lung or severe heart conditions, anyone who lost a lot of blood during the operation, or if the surgery itself was a marathon session. Each of these factors just makes the body that much more fragile, that much less able to bounce back on its own. Now, if you've ever stepped into an ICU, it can be a lot, right? The constant beeping, the lights, all the tubes and wires. But here's a better way to think about it. All that technology, those aren't just scary machines. They're the patient's lifelines. They're the eyes and ears of the medical team, feeding them a constant, real-time stream of data about everything happening in the body. Let's start with a really crucial piece of kit, the central venous catheter, or CVC. This is no ordinary IV. Think of it as a multi-lane superhighway that goes directly into the body's central circulation. It's carefully placed in a large vein, so the tip sits right there at the entrance to the heart. And because of that prime location, this one line is a total workhorse. It lets the team push massive amounts of fluids or blood in quickly, deliver potent drugs that control blood pressure, and it gives them a direct pressure reading from the heart itself, the CVP. It's their all-in-one window into the patient's fluid status. Okay, next up is the peripheral arterial line, or what everyone just calls an ART line. Now notice the name, arterial. Instead of a vein, this little catheter goes directly into an artery, usually the one in your wrist, and it provides something a regular blood pressure cuff just can't compete with. What's the big deal? Well, it's all about accuracy and speed. When a patient's blood pressure is unstable, you can't wait a minute for a cuff to inflate and deflate. The ART line gives you a continuous, beat-by-beat reading. Plus, it's a painless way to draw blood samples over and over. And most importantly, it gives them the mean arterial pressure, the MAP. That's the number that truly tells them if the body's vital organs are getting enough blood and oxygen. So with all this incredible data pouring in, the team faces one of its biggest challenges, managing blood pressure. And honestly, it's like a high-wire act. It's a delicate, moment-to-moment balancing act where leaning too far in either direction can be an absolute disaster. On one side of that tightrope, you have blood pressure that's too high, hypertension. That can literally blow out a fresh suture line and cause massive bleeding, or just put way too much strain on a struggling heart. But if it's too low, hypotension, the organs start to starve for oxygen. That can trigger a heart attack, a stroke, or kidney failure. So you can see why the team is constantly making tiny adjustments to stay in that very, very narrow safe zone. And just to put a number on the too high side, if that top number on the blood pressure reading, the systolic pressure, climbs over 180, that's officially a hypertensive crisis. It's not just a bad reading, it's a 5-alarm fire. It's a signal that organs are actively being damaged and the team has to bring that number down, and fast. Now, that risk of organ damage leads us to the single biggest fear after a major vascular surgery, a postoperative myocardial infarction. In other words, a heart attack. Trying to spot a heart attack in a post-op patient is basically detective work. Why? Because the classic symptom, chest pain, is often completely masked by all the anesthesia and painkillers. So the team has to look for other clues. First, they're glued to the ECG monitor, looking for subtle electrical changes that scream, this heart muscle isn't getting enough oxygen. And second, they run blood tests for a protein called troponin. It's the smoking gun that only leaks out when heart cells are damaged. Okay, so once they suspect a heart attack, they have to figure out which kind it is, because the treatments are totally different. A STEMI is the big one. It's caused by a complete artery blockage. That's a true medical emergency, where they have to rush the patient to the cath lab to physically open up that artery. But a non-STEMI, which is actually more common after surgery, is different. It's caused by a severe mismatch between the heart's oxygen supply and its demand. The fix here isn't a procedure. It's about medically managing the situation, cranking up the oxygen, controlling the heart rate, and doing everything possible to reduce the heart's workload. After a long, stressful surgery, the lungs are often just exhausted. They're weak, and they can't do their job. That's why so many patients wake up with a breathing tube connected to a ventilator, a machine that's literally breathing for them. So the next huge goal is to help those lungs heal and get strong enough to take over again. So how exactly does that work? How do you go from being totally dependent on a machine to breathing on your own again? Well, it's not like flipping a switch. It's a really careful, deliberate process. It's really broken down into two main phases. First up is readiness testing. Basically, every single day, the team will lighten the sedation to see if the patient is even strong enough to start trying. If they pass that initial test, they move on to phase 2, liberation. This is the big final exam. It's a spontaneous breathing trial where they turn the ventilator support way down and make the patient prove they can do the work. If they pass that trial, the tube comes out. It's a huge milestone. But you have to remember, it's not just about the heart, the lungs, and the blood pressure. The whole time, the ICU team is also playing defense, guarding against a whole bunch of other silent threats that can pop up when the body is this vulnerable. One of the scariest is coagulopathy, when the blood suddenly loses its ability to clot properly. Doctors use lab tests like the APTT and INR as clues to figure out what's going on. This table is kind of like their decoder ring. For instance, if one test is off but the other is fine, it might point to a blood thinner like heparin, and they can reverse that with a specific drug. If both are way off, that could signal a much bigger body-wide problem. It allows them to diagnose the problem quickly and give the exact right treatment. And then there's this really insidious threat, postoperative delirium. This is a state of sudden acute confusion, and you might be shocked to hear how common it is. It can affect more than half of some of these patient groups. And this isn't just someone being a little groggy. It's a serious medical problem that's linked to much worse outcomes. To spot it quickly, the staff use a really clever tool called the Confusion Assessment Method, or CAM. It's basically a simple checklist they can do right at the bedside. They're looking for two main things to start. Did this confusion come on suddenly? And is the patient having trouble paying attention? If the answer is yes to both, they then check for either disorganized thinking or a change in consciousness. If they find one of those, boom, that's a diagnosis of delirium. This quote just perfectly captures the terror of a postoperative bleed. It talks about a bloody viscous cycle. What that means is the bleeding uses up all the body's clotting factors, which makes the bleeding get even worse, which uses up more factors. It's a terrifying downward spiral that can lead to sanguination, a catastrophic, rapid loss of blood. It just highlights how every second counts. So when you look at this whole picture, this incredible web of technology, constant monitoring, and split-second decisions, it all leads to a final thought. This entire intense, complex battle to stabilize a human body, it's all in service of one thing, really. It's about giving that body a fighting chance to do what it does best, to tap into its own amazing, incredible will to heal itself.